Gout is nothing but the deposition of the urate crystals in the soft tissue and the joint because of the hyperuricemia, or which might be caused because of increased production or the decreased excretion of the uric acid. Now, the most common site for the occurrence of the gout is the first metatarsophalangeal joint. The first metatarsophalangeal joint is the most common site for the involvement of the gout. Now, the joints that are involved includes the lower limb is more commonly involved than the upper limb, and in the lower limb, the smaller joints are more commonly involved than the larger joints. And when the axial skeleton is involved, it is the thoracolumbar joints are more commonly involved than the cervical joint. The thoracolumbar joints are more commonly involved than the cervical joints. Large joints are usually not involved, but when it is involved, it is usually seen in the elbow joint, and sometimes it can also be seen in the knee joint. Now, when the hand is involved, this is again the gout can involve the distal interphalangeal joint. The distal interphalangeal joint is involved in osteoarthritis or erosive arthritis. It can be involved in the psoriatic arthritis. It can be involved in the chronic reactive arthritis, and it can be involved in the gout. So these are the joints which are commonly that are involved in the gout. So specifically, we have to remember that the lower limb more common than the upper limb. The smaller joints are more common than the larger joints. And when the axial skeleton is involved, the thoracolumbar vertebral bodies are more commonly involved than the cervical vertebral bodies. When the uric acid deposition happens, the deposition mainly happens in the juxta-articular location in the soft tissue as well as around the joint, and this will cause some sort of erosions which are usually present juxta-articular location. So there will be some overhanging borders. This is a classical feature of the gout, is this overhanging border on a juxta-articular erosion on an X-ray is classical, and also there will be periarticular amorphous deposition of the tophi which might undergo calcification in the later stages. Now, this will appear hypointense on both T1 and T2 weighted image when it undergoes calcification, but when there is no calcification in the initial stages it might appear T2 hyper, but this tophi will also show enhancement on MRI. In X-ray we can see some punched out lesions in the juxta-articular location with overhanging margins like this, and also in the later stages we can see the intra-articular extension of the crystals which might look like the enchondroma in an X-ray. Also, when we do ultrasound, we can see that the crystal might have deposited on the cartilage. When the crystals are deposited on the cartilage, the ultrasound will give the first reflection from the cartilage and second reflection from the subchondral location. So this classical double rim sign is seen on ultrasound of gout. In this image again we can see that there is a well defined erosion which with the overhanging margin the margin, and also see how classically the cartilage is not involved. The late involvement of the cartilage or not involvement of the cartilage is one of the important feature in the early stage of the gout, is one of the important feature, along with the juxta articular erosion with the overhanging margin. And the type of erosion here is a well marginated erosion, like how we see here. Again we can see some well marginated erosions which are present here, along with the soft tissue swelling, and also we can see some ill-defined erosions even in the proximal interphalangeal joint. So and even in this image we can see that again there is one well-defined erosion with overhanging margin. Also some dense tophi can be seen around the joint, and the joint involvement is relatively less compared to that how the juxta-articular involvement is. And in this image of knee showing that there is a hyperdense effusion in the suprapatellar bursa. Also there is some prepatellar tophi, hyperdense tophi, along with calcification of the vessels. This is a case of end stage renal disease in which the patient is present with the gout and calcification of the vessels. This image again we can see a well corticated and well defined lesion, well defined erosion which is present in the first metatarsopharyngeal joint without significant involvement or without involvement of the joint cartilage. Whereas in the second image, if we see that there is a severe erosive changes even involving the cartilage changes, even involving the joint cartilage, and also we can see multiple areas of the tophi deposition with no much calcification within. Whereas in this image again taken which is involving the first metatarsopharyngeal joint with some dense tophi along uh, which also with the dense calcification is seen in this area, uh, which will suggest us two DDs. One is either a matrix containing tumor or it can be a gout. So a large tophi usually mimics or matrix formation, matrix containing tumor also. In this image we can see that the neck is narrowed and it is destroyed by the tophi, hypointense tophi which is deposited around, and also this tophi from here it's also extending in the periarticular area causing the erosions in the base of the phalanx, the base of the proximal phalanx. Also it is causing the erosion of this sesamoid bone as well. So the PD image here is showing there is a deposition of the tophi in the olecranon bursa involving the triceps tendon and causing the erosion of the olecranon process. Now the same patient PD fat saturated PD image showing hyperintense lesion on a sagittal image on a olecranon bursa also involving the triceps tendon and causing erosion of the olecranon fossa, and a lateral radiograph showing dense calcification in the tophi, and here we can see some erosions and even edema in the bone marrow. Edema is seen in the knee